Seeing none, it shall be introduced. Are there other bills to be introduced at this time today? Yes, sir. Representative Bryce.
Thank you, Mr. Chairman. On behalf of the Association of CMHCs of Kansas, I would like to introduce 23 RS 0535. It's providing that certain mental health medications be available without prior authorization to treat Medicaid patients. Thank you.
Very good. Are there any questions for the introducer of the bill? Is there anyone opposed to introducing this bill? Seeing none, it shall be introduced. Are there other new bill introductions to jazz things up today a bit? Okay, so I do have a bill I want to introduce at this time, and its number is RS 0468. This comes to us from the Pam Scott from the Funeral Home Directors Association on behalf of providing apprenticeships actually for embalming. So that is going to require a codification change. So with that, is there any questions or opposition to my introducing this bill? Okay, it shall be introduced. Are there other bill introductions at this time? Yes, Representative Reese.
Thank you, Mr. Chair, temporary. Found my second one. This is 2023 RS 0437. This is in regards to conversion therapy. Let me open this up. An act concerning health and healthcare relating to behavioral and mental health, prohibiting certain licensed individuals from using conversion therapy on minors.
Sounds interesting. Okay. Are there questions for the introducer at this time?
On behalf of me.
Is there any opposition to the introduction of this bill? Then it shall be introduced. So with that, on today's agenda, as I understand it, and just having learned that I was pinch hitting, I think we'll go straight into our presentations unless there's other business to come before the committee at this time. Is there anything from the members? All right, then we'll move into our docket, and that is presentations today, and we have several. We have presentation from the Kansas Health Centers, Linda Mowbray, and presentation on Leading Age Kansas from Rachel Monger. And let you come to the mic and introduce yourself and give us your presentation. We're all looking forward to it.
Thank you, Mr. Chair. Temporary? Very good. I'm Linda Mowbray. I'm President and CEO of the Kansas Healthcare Association and the Kansas Center for Assisted Living. We are a trade association, so we represent not only the individuals living in nursing homes and assisted livings, but we also represent the staff, the management, the ownership, and the profession as a whole. We do have a national affiliate. It's the American Healthcare Association, and the chair of the American Healthcare Association is a name that many Kansans are familiar with, and that is former Governor Mark Parkinson. So he is our national leader, if you will. On a statewide basis, we represent assisted living, nursing home, adult daycare, home plus, residential health care, nursing facilities for mental health, a whole host of licensed adult care homes across the state of Kansas. We've been around since 1951, and as you know, things in the last 3 years have been very difficult for nursing homes and assisted livings in the state. I requested that we have an opportunity to speak with all of you because there are so many new people and new faces on the committee, and elder care in Kansas is such an important topic and such a need for many individuals that we wanted to give you a little bit of a briefing as to the state that we find ourselves at this point. Now, I have a whole lot of documents for you, and you'll find those online and in your packet. The very first document is the classifications of long-term care. And that document, it's considered Doc 1 and called Classifications of Care, tells you the licensed categories for care in Kansas. And there's many. But the thing to remember is that the skilled nursing facilities are the ones that the federal government regulates. All the rest, they are state regulated. So you are the rule maker and the decision maker with those kinds of facilities. The nursing homes and the long-term care units of the hospital, they are funded by Medicare and Medicaid. Medicare is the federal health insurance program that you pay into ever since you started working. Medicaid is the program when you deplete your resources and are still needing care and qualifying based on age and your income. So our homes have several sets of rules that they have to follow by. And this sheet defines what they are. And if you ever need help with that, please let us know. We've also provided for you a laminated copy of acronyms. And I believe our committee assistant, David Long, has provided those for you in your packet. And those acronyms are a helpful way to keep us honest with you when we start throwing jargon around. And please, if we throw jargon around, I apologize in advance, and we will try to stop and explain what we mean. So when we start talking about ADLs, it's the activities of daily living. Does that tell you any more about what we're talking about? Probably not. So it's good to know when we're talking about these different acronyms, we're talking about things that you normally do by yourself, or whether wash or bathe or eat or whatnot. And those are important differences in our world. The third document that I have in your handout for you is a very, thank you, might need those later, is a very scary map. And it's a risk map that was put out by AHCA. And this risk map was from April of last year, so it's almost a year old. And it goes through and talks about facilities that are at risk of closure. And back in April, 51% of long-term care in Kansas was at a certain risk for closure. Closure can mean an entire building closing down, a wing closing down, decertifying beds, stop taking admissions. The risk is real. The second page of that will talk about the number of individuals that we're caring for, and that's what we call our census. And when census is down and beds are empty, that's how facilities get paid. But if we don't have the staff to take care of the residents, we can't responsibly bring new residents in. The third page will talk to you about what areas are being affected the most. And yes, people in poverty and people in rural communities are hit very, very hard by this crisis. And then the fourth page will show you our crystal ball of what the future's coming. We know that people are getting older in Kansas, and the capacity is not there in just a few years to care for the people that will need care. Fifth document talks to you about the workforce. I can't say enough about how critical it is that we have well-trained, well-qualified workforce so that we can care for our elders. Now, the next document that you have for a referral is my very fancy thumbtack map. And that's in your folder as well, or in your electronic file. This is a very sad map. This is in the last 3 years, the number of nursing homes that have closed in the state of Kansas. 7% of nursing homes have closed in the state of Kansas. Is your county on there? Are your constituents affected? The next handout shows you exactly where those closings are. The one in red is one that's coming up in March. It's not closed yet. And these are only the ones that we know about. There are buildings out there, I get calls on a daily basis, the financial risk. Do I know anybody who's buying nursing homes? What can we do to keep afloat? One of my board members today told me that with her 12 skilled nursing facilities that she oversees, their staffing agency bill every month is $1 million. We've got to do something to keep these homes around. The next document I have is again, more job reports and the loss, and I don't need to go over that with you. We have never been this low in our workforce since 1994. We need to have high-quality skilled nurses, nurse aides, but also laundry, housekeeping. We have got to come to a place where we value our elders as much as we value children and schools and other populations. We have to fund these programs so we can keep them going. You know, none of us are getting any younger. And while we'd all like to believe that we will never, ever, ever need to go to a nursing home or an assisted living, the reality is a lot of us are going to, at least for a short amount of time, to get some rehab. And my colleague Rachel Munger will go over another handout with you, and that's a survey that we have done with our members, their members, and other entities across the state that talks about their ability to take new admissions in. And keep one thing in mind when you hear her information. Those new admissions may be people that need long-term care, or they may be people that are just trying to recover from a hip fracture or a stroke or a heart attack. They need care on a short-term basis. And when the nursing homes, the post-acute rehabs are saying, no, we don't have room, that can be a real issue, because you may not find a home in your county. It may be 2 counties over. And speaking of that, in 2013, just before or just as CanCare was starting, there was a skilled nursing option in every single county in Kansas, 105. At the beginning of the pandemic, we're sad to tell you that it was down to 99 counties that had a skilled nursing option. I believe we're down to 97 with more counties at risk. And what does that mean for us? It means that you don't have care in your community for your elders. What I'm going to ask you to consider as we go forward is stabilizing the funding, making sure that we have the dollars and resources available so that we can take care of our elders. You know, I bring these issues to you today, but I also hopefully, as the session goes on, will bring solutions as well. Some initiatives that we're working on for workforce, for funding, for bringing education opportunities for healthcare workers. So I'm not just coming today with my hand out. I just want to lay the field as to what we're dealing with in this profession, and that let you know that I do stand ready, and the Kansas Healthcare Association and Kansas Center for Assisted Living stand ready to help find the solutions to these problems, work together so that we'll be able to say how proud we are of the long-term care that's provided in Kansas. I'll stand for questions at the appropriate time. Thank you.
Committee, I think what we'll do is go ahead and let Rachel give her presentation, and then we'll just have questions for both, if that's okay, Linda. Is that okay with you?
Absolutely.
Really appreciate your coming and giving us your presentation, and I think there'll be a lot of questions. So, but I want to make sure that Rachel gets some time too.
Excellent. Thank you, sir.
I should probably wait for you to call.
Next, we have Leading Age Kansas to present, and I'll let her introduce herself. I've known her since I've been here, and she does a great job, so go ahead.
Thank you very much, Mr. Vice Chair. I am Rachel Monger. I'm the President and CEO of Leading Age Kansas. And Leading Age Kansas is the state association for nonprofit and faith-based senior care in the state. We have 160 member organizations. Linda listed all the senior care options that her members cover. We're the same, and you can find that at the top of my written testimony. As nonprofits, our members are run by boards of directors made up of community leaders. Most of our members are in communities of less than 4,000 people, and most of them are standalone, meaning they're not part of a larger chain or health system. They're out there doing things, on their own and for their communities. I'm very thankful to Linda for laying out so many things and the landscape of long-term care. Very helpful to tee up my presentation. You heard Linda talk about the number of total facility closures in Kansas since the pandemic. If you also look at facilities who have managed to remain open but have delicensed or closed portions of their buildings, at the end of 22, that number climbs to 47. And if you count the 2 Leading Age Kansas members that announced closure at the beginning of this year, we're now up to 49, and that's just in January. The issues we're talking about today are not new, but since 2020, they have overwhelmed our field like a tidal wave. And in these last 3 years, we still haven't managed to get our legs back up underneath us or even our heads above water. When preparing for this hearing, we really thought it was important to share the data with you all to support the stories that you hear with the numbers. And because we are such a highly regulated field, the government collects voluminous amounts of data on pretty much everything we do. And that is what is behind all these numbers that are going to be in front of you and I'm going to talk to you about today. There are 2 aspects of the crisis we are in that are always intertwined, and that is funding and workforce. So starting with financial health data. We all know the inflation we're experiencing on goods and services. Long-term care suffers under that too, but we really want to focus on labor costs increases. Since the start of the pandemic, labor costs in senior care have grown by double digits, 22% in residential care, 24% in assisted living. And really the worst statistic or highest statistic of all comes from contract labor, also known as temporary healthcare staffing agencies. The annual cost of staffing agency labor has grown to 270%. So when you hear from your healthcare providers and long-term care providers back home about staffing agencies, that's why. And we really, from even just looking at the closure numbers, we cannot stay on this trajectory. The majority of the care we provide is funded by Medicaid. Medicaid doesn't cover labor cost increase of 22%, let alone 270%. And even when Medicaid payments are supposed to be based on the facility's cost of care, it's always years behind, and there are caps built into the reimbursement formula. So past a certain point, the government doesn't even pay you for your costs. And even when the legislature steps up and fully funds our Medicaid rates, like they did last year, and we are so incredibly grateful, even when you did that, our providers still bleed money when it comes to Medicaid. KDAD's calculated that for an average facility this year, Medicaid payments only covered 90% of the cost of care. So a 10% loss on each Medicaid resident in a building each and every day, it's a lot of costs for a facility to eat. And that 10% loss is the best case scenario for many of our members. So moving on to workforce numbers. Our workforce has shrunk by 10% at least. Our reliance on staffing agency labor has grown by 90%. So I will say that again, if you hear from your providers back home about staffing agencies, that is why. A 90% increase in usage at a 270% increase in cost. And our workforce challenges aren't just causing financial issues for providers. They are causing serious access to care issues for many seniors around the state. You may have heard from your hospitals frustrated by their inability to discharge patients. We certainly have heard from those hospitals. The reason why is, Linda already said, our homes aren't taking people. They don't have the staff to safely do so. So to get an idea of how far this problem goes, all of the long-term care associations sent out a survey to our members asking for admissions-related data for November 2022. 116 nursing homes responded, which represents about a third of the facilities in the state. 60% cited insufficient staffing as the primary reason for declining a new admission, and 44% had a waiting list for new admissions. And here's another important number. We asked 110 facilities how many admission referrals they turned away in November. Between them, they turned down 1,194 admission referrals from hospitals and other settings in just the month of November. So you take that number times the other 2/3 of facilities in the state, and it's month over month, and you have tens of thousands of seniors searching for care being turned away. And it's mostly due to insufficient staff. So to sum up all of the many numbers I just threw at you, our long-term care system is collapsing under the weight of high costs and low staff. It is hurting the quality and the availability of services in our community, and we are really struggling to find solutions. Like the rest of the country, Kansas is rapidly aging. In the next 10 to 15 years, our 65-plus population is going to jump another 250,000, and it'll keep rising as the percentage of our 85-plus population increases by triple digits. Kansans and their families need care. They need it in every part of the state. And at a time when we should be investing in and growing our senior care options in this state, we are instead contracting at every level. So the issues we faced did not happen overnight. They existed pre-pandemic. And there are no simple and easy answers to fix it overnight. But there are things that we can do now and things that we can invest in for our future to grow our services and supports and strengthen that senior care infrastructure. So a few ways that you guys could help this session is making sure Medicaid reimbursement and provider costs are fully funded. We already went over our Medicaid formula is not perfect, but it is the only thing we have right now, and we cannot afford to fall behind. Second, staffing agency reform. So we know there are serious concerns and questions about past proposals that would have limited staffing agency charges. We have moved on from that. And we are asking the legislature now for help keeping that labor market free and fair. We have to stop staffing agencies from strangling our labor markets with non-compete clauses and buyout clauses in their contracts. Nurses and nurse aides who decide to leave the staffing agency and work in our buildings they've been assigned to often can't. The staffing agency points to their non-compete clause. When agency nurses come to a facility asking to be hired, the facility has to say no because they cannot afford to pay the $30,000 buyout penalty in the staffing agency contract. Our homes cannot compete with staffing agency wages. We can't seem to climb out of this labor cost spiral that we are in with staffing agencies and their administrative charges, and we can't seem to get a foothold on the path out of this crisis. So we are asking the legislature to please help us with this, at least one thing. For the nurses and nurse aides that want to return to our buildings and return to our residents, please give them the freedom to do so. And please give our providers the ability to hire those nurses and nurse aides without penalty. And last, we ask you to support workforce development and worker-friendly policies. We know there will be plenty of those coming through because workforce is a concern everywhere. We know we are not alone. And we will certainly be supporting any of those that help with training and recruitment of healthcare workers, and then policies that will help more people enter the workforce and stay in the workforce. So before wrapping up, I will point you to my written testimony. Attached to it is a Leading Age Kansas situation report. It has a lot of the numbers that I talked about today and even more, including a map of Kansas with senior care deserts. We have also broken down that data by each House and Senate district, and so I have that available to you if you'd like it. It even goes into how many people in your district live more than 30 minutes away from a senior care option. So thank you very much for your time today.
Rachel, thank you very much, and also Linda, thank you. And gosh, I've got a bunch of questions, but I'll let the committee ask my questions for me. So, committee questions. Let Dr. Clifford.
Thank you, Mr. Vice Chair. For Linda, if you don't mind coming to the podium, your closure chart, not the pin chart, but the next one, it had an asterisk next to the Morton County Senior Living Community, so that triggered a question in my mind. I'm a little bit of a glasses half full type person, and I know that the adjacent county, Stevens County, opened a wonderful new facility in the last decade, and I just wonder if there's any good news like that out there.
There have not been many nursing homes open in the last 3 to 5 years. There have been a few. The overwhelming number of homes that have opened in the last few years are under a state licensed only category called Home Plus. Those are homes that are for 12 individuals or less. Many of them are only licensed for 5, 6, or 7. They're not funded by the federal Medicare program, and the only way they can get Medicaid support is through the Home and Community-Based Services waiver, which we're very thankful that they can use that waiver, but they have closed at a very rapid rate, too. When we look at the closure map for the Home Plus, which I did not provide for you today, but I certainly can, there have been about as many close as they have open because they're small businesses that just can't. It's not sustainable with staffing, with their liability insurance and all. Some of the good news, if you will, with these counties, the asterisks by the ones, and I apologize for that, they did leave other types of care open. So with Brandon Woods and the Forum, they left their assisted living beds open. So the entire facility didn't close, but their nursing home beds did. And sometimes they're in attached buildings and sometimes they're adjacent. Same thing with Morton County. They still have availability for other types of care, just not the licensed nursing home care.
No, go ahead. Representative Clifford, you
Thank
may
you, Mr.
ask
Chairman.
another question.
Last question is a follow-up. So decades ago, it seemed to be a model for the rural and frontier hospitals to put in a wing as part of their business plan. Do you see those closing as well, or are they able to offset the cost because they have a rural hospital attached, or vice versa?
So we have seen long-term care units of hospitals close. Many of them are in membership with Leading Age Kansas as part of their nonprofit mission. So I'll look to my colleague, Mr. Chair, if I can, to see her response.
Just introduce yourself again, please.
Yes, Rachel Monger with Leading Age Kansas. And we do have a lot of long-term care units in our membership, and they are struggling. We certainly have seen closures or reduced beds. We have also seen rural hospitals abandon the long-term care unit model, and they switch to what are called intermediate swing beds, which is a whole other alien world that we are still trying to get our arms around. But it's because they could not, even with the hospital supporting it, they could not make it work. And it's sad to see, just like anywhere else. Yeah.
Thank you for pointing that out. That's exactly what I've seen when I've gone around. I just didn't know what they called it, but it looks the same. But I know the rules are different. Thank you, Mr. Vice Chair.
You bet. We'll move on to Representative Bueller. Do you have a question?
Thank you, Mr. Chair. I do. So let me, and I don't know if this is to Rachel or Linda, but when you talk about what you need from us, whether it's fully funding Medicaid reimbursements or the staffing agency reforms. My question kind of goes back to if you had to define best in class or world class, whether it's in this state or some other part of the country, when you talk about reforms for staffing agencies and some of the buyouts, are there examples of what you would consider world class that we ought to consider or model here in Kansas? And again, and the reason I'm asking the question, and I'm fairly new to this, but in virtually every agency I've heard speak in the last 3 weeks has talked about staffing, has talked about funding, and at some point we got to find out what is best in class or what is world class that we can make some advances in our state. So that's kind of what I'm curious about. Thank you.
Rachel Monga with Leading Age Kansas. So 2 avenues there. On the Medicaid funding part, I don't know that we can point to anyone who has really figured that out. It is a complex system, and it's questions that every single state and every single legislator is asking is how do we make this work, not just for long-term care, but mental health and, developmental disabilities. It's a lot of people. So we are always seeking those new models, and when we come up with ones that we see really work, we bring them. On the other one for staffing agency reform, as I had said, we are moving away from the charges and all of that stuff, and the bill that we would like to bring forward is based on a bill that was passed in Iowa last year, and it really focuses on getting rid of the buyout clauses and the non-competes and making sure that the staffing agencies are behaving like businesses should and have workers' comp insurance for their employees and things like that, just putting a standard there that we can track.
Okay, thank you. Thank you, Mr. Chair.
Yes, take a question from Representative Bryce.
Thank you, Mr. Chairman. I had a question for President Mowbray. The scary map. It looked like Kansas was the worst, in the worst possible situation out of all 50 states. And I was looking at all these factors that are going into hindrances for keeping these facilities open, and it was, of course, financial stability, workforce issues, staffing issues. They mentioned, I think, COVID and maybe demographic shift and different things, but I'm thinking all of these factors apply to all 50 states. And what is it about Kansas that makes us the worst? Thank you.
Mr. Chair, if I might. We are not the worst. We're highlighted in one of the high red areas as a high-risk area, but in different parts of the demographic, whether it's census, workforce, finance, whatnot, it's kind of an average. So the information in the different tiers, if you will, we're not the worst. What makes us have a great challenge is because we are rural and we are frontier and we are aging and our younger people are moving away from where they were born, where they were raised. It's not any different for any other industry, any other profession. The difference is we're a 24-hour-a-day business. We can't decide to close on Mondays because we don't have the staff. We have to be able to, look at workers and attract them and to keep them. And as my colleague had said, when they have an opportunity to work for a staffing agency for more money, good for them, fair market, go to work for them. But when they are tired of that and want to come back and have a place to call home, because this business is about people and the relationships that we make and the caring, and the best care is given by consistent staffing. When that nurse or nurse aide wants to come back and have roots and have home, and the nursing home can't because of non-compete or those huge buyout numbers, that's really limiting the ability for an employee to move around as well. So staffing wage caps, it's not a great idea. We don't like that. But capping the ability to somebody to move and change jobs, I don't think we really like that either.
Very good. And follow-up, yes, Representative Bryce.
Thank you, Chairman. Just a quick follow-up. From what I understand, one of the things that we could have as legislation is removal of these non-compete clauses, but playing the devil's advocate, if I'm a staffing agency and I can put a non-compete in there, I can have, has a downward push on my cost because if we remove the non-compete clause, it would tend to inflate the cost for staffing agencies because they don't have that reassurance that they can retain employees. So I'm just wondering if that would be counterintuitive to actually remove the non-compete clause. Thank you.
Sir, in my opinion, it's not counterintuitive. Right now, the individual working in the nursing home can go down the street for 10 cents more and then come back up the street for 25 cents more. So having that non-compete between nursing facilities hasn't helped us, but it is a fact that's there that we can, and we don't want to limit workers' ability to go where they want to go. To have that non-compete for the staffing agencies, quite frankly, in my opinion, gives them an unfair advantage. We can't put those into place, but yet they can put them there and basically keep those staff in place and keep ours locked out.
Thank you. I think we'll move on then to a question by Representative Bergkamp.
Thank you, Mr. Chairman. I guess if you don't mind staying up there for a second, is there a way that we can keep more people out of nursing homes, or is there a way that we can address health on the front end before they get to the point of needing that? And who might be the best to address that? Thank you.
Mr. Chair, thank
Yes.
you. No one wants to be in a nursing home. Let's face it, you didn't wake up this morning saying, gosh, I wish I was in a nursing home so somebody could walk me to the bathroom and get in my business. Nobody wakes up wanting to be in a nursing home. So what do? It's a public health issue. It's lifestyle. It's also community resources. A lot of emphasis has been put towards, what can we do to keep people in their home? What can we do to help individuals be as productive as they can in the least restrictive environment? And that's important, and we stand behind that. Many of our members provide different levels of services and care, so it's not that we're just looking at nursing homes. Fully funding the continuum of care is one of the best ways we can do that. The other issue is staffing. We can't staff. The home care agencies have difficulty staffing. And you start looking to those rural counties and those frontier counties, and you have miles and miles between the home visits. I don't have an answer for that, sir. I don't. There's not enough workers. The distance is great. But I do think that we need to look at root cause. We need people that are willing to do this. And the only way to find those people that are willing to do this kind of work is to make it attractive to them, open the door and the possibilities, and take down whatever barriers we can possibly take down so that they can put their toe into healthcare and find the niche for them.
Thank you very much, Linda. We have a question, I think, from Chairwoman Landwehr.
Well, not so much a question, but I think to answer a little bit of where Representative Bergkamp was going is that's why we have our HCBS waivers that we have out there for the frail and elderly, because it does help them to stay in their home. But in some cases, people aren't, even though they're cognitive and they're doing pretty good, but they may not be safe in their own homes. So those are things we look at. We are an aging population state, as you heard stated earlier. Assisted living, and you two ladies can correct me if I'm wrong on this here, but assisted living is primarily private pay.
Madam Chair, assisted living are eligible to participate in the HCBS program for the frail elder. Not many, I shouldn't say not many. Those that do tend to limit the number of individuals on the HCBS waiver because it pays at such a lower rate than what the private pay rate is.
But the HCBS doesn't pay the monthly rate.
That
for
is
the- for the
correct.
facility.
They are not allowed to
For the
pay
assisted
for
living.
room and raw food.
Right. It's one of the things that, people, try to encourage. I know that former Insurance Commissioner Sandy Prager was one on this, and we did a long-term care partnership so that if people would buy long-term care policies, say for, $300,000, that should they expend that whole $300,000 for their care, that 300,000, and had to go onto Medicaid, then they could exempt $300,000 of their assets because they tried to be as responsible as that they thought that they could. And so I just don't, it's something that we fight all the time on this here. These jobs in these nursing homes are very labor intensive. They're emotional, they're physical, and it's hard to get the staff. And workforce in all of healthcare, we are at crisis mode. And you guys may have covered this before I come back in, is that, we're not closing, quote, our big nursing homes, but we're shutting down beds, so we might as well be closing homes. And I don't know at what point that we're not going to have places for seniors to go, because when they don't have the financial capacity or even the mobility, et cetera, nursing home is their last option.
Historically, we had county homes, and that was before we had Medicare. And I'm old enough, I remember those days. I went to the county home for some family members, and it fell on the county. And they were draconian conditions. I mean, conditions are very challenging now, and they're diminishing. We get all that. But county homes were even worse. And who knows, we may recycle back to county homes at the rate we're going, and that's really scary to me as a provider. But I just had to say that. I do have some questions, but are there questions from the committee? Yes, Representative Ellis.
Are there still bed tax on these? The state still tax?
Yes.
Provider tax?
Yes, we have a provider tax. There are two different tax rates. The provider tax is a mechanism that taxes the number of licensed bed a nursing home has at either a high rate or 1/6 of that rate. The money that is raised by this tax is leveraged against federal dollars, and with the federal, they call it an FMAP. That money and the additional federal money comes back to the state for the disbursement in the rates. Right now, the rate for nursing facilities, the high rate is $49.08 per bed per year, as determined on July 1, for how many licensed beds they have. The lower rate, the 1/6 rate, is $818. How do you get to use the lower rate? You either are a small facility, under 46 beds. You are a huge facility that does over 25,000 Medicaid days a year. Or you're a continuing care retirement community, now often referred to as life care facilities?
Life Plan Community.
Life plan communities. I still don't have that one down yet. My apologies. But the CCRCs also enjoy that lower rate. So as we look at different homes, the provider tax is a great example of driving the market, if you will. There are so many homes in Kansas that are under 46 beds, so they can do the lower rate. A lot more CCRCs than there used to be. And because of census and staffing, a whole lot less doing 25,000 Medicaid days a year. So the majority of the homes are paying that lower rate and not the higher rate.
Thank you, Linda. I think Representative Landrieu has some important comments.
I don't know so much about that. Well, and the other thing that we deal with is that our nursing facilities are under a lot of licensure requirements, a lot of rules and regs. The inspections are something else that they go through. It's pretty tremendous. And then one thing I knew I had forgotten earlier when I went to speak is you heard us talk about the PACE program, and it's been helping us somewhat with that, Representative Burkamp, and it's been growing across the state. So, Kansas has been looking to alternatives, but it doesn't mean that we're not always looking for something different. I know that between Linda and Rachel, if they had magical ideas, I guarantee you that they would tell me, so.
All right, very good. Representative Blex has a question, I think, for us.
Thank you for your presentation. Thank you, Mr. Chair. And the job duties, in my simple mind, has been not highly desirable for a number of years. But yet, since COVID and all the regulations, the shutdown, the negative PR on the nursing homes, I can't get in and see grandma for the last time. It seems like now we've got this huge shortage that nobody, so I guess my question is how much do you think that regulation and things have, and maybe paying people more than we should to stay at home and do nothing, how much has that contributed to the fact that you're dealing with a super shortage?
I won't speculate on the reasons why people don't come to work or why they don't want to work in this profession, but I will say to your point of regulations, yes, regulations make it very, very difficult because you want to do your work, you want to do a good job, but the stick that the federal government has it's a punitive position. They're not looking to catch you when you do it right. It's wacky when you're not. So it's a tough job, and it is not necessarily the highest paying job. But I will tell you, sir, that my first job out of college in 1987, that's how old I am, was in a skilled nursing facility. I had no idea what I was getting into. But for some, it's a calling. It's a love. And I stayed there for 14 years and then moved to the association so that I could help represent those nursing homes. For some people, there is just a need in their life to have that contact with elders, to have that support and that family. There's also a community of individuals where that certified nurse aide may be the highest paid, highest educated person in their family network. And they're proud of being a certified nurse aide. We have opportunities to where they can advance if they'll come in the door and give it a chance and let us open those opportunities. We've just got to figure out a better way to get that door open for folks to put their foot in.
So, and I know there's a lot there, but what can we do as state legislators to really help those situations? It almost appears to me that a lot of them is out of our control. Now, certainly the general response is throw more money at it, but that's not always the answer either. So what's your opinion? What do we need to do?
What I believe you all can do to help is to be our partner, because we do have initiatives. We do have ideas. We do have suggestions. Workforce initiatives, the internship initiatives, the outreach. We can't do it in a vacuum. We can't do it in a void. And we have to be very cognizant that there's some really attractive businesses out there that are trying to do the exact same thing we are. Trying to attract new work, new labor. So what do we do to break down those barriers? Is it a tax credit? Is it reimbursement for their training, their salary? There's many different things. I would just ask you all to please keep an open mind when different healthcare sectors come and say, hey, we've got this idea. Because we are going to have to solve our own problem with your help.
Thank you, Linda. I think maybe Rachel had wanted to chime in a little bit there, please.
Yes, so some of the specific things we are looking at that I know you guys will see, like apprenticeship programs. That's something that healthcare really hasn't done a lot in the past. And so we're working with educational institutions and the Office of Apprenticeship and other healthcare providers to figure out what that looks like for us and how it intersects with the million regulations that we have and licensing requirements. At our foundation, we hand out thousands of dollars of scholarships every year for people who want to enter senior care or advance their careers. We have leadership programs that we're expanding for our members as well. And then later into 2023, you're going to see us teaming up with other human services sectors, such as providers for intellectual and developmental disabilities, child welfare, mental health, to come together and probably come back to you with some proposals of how we can expand and improve the ramps into human services, the training and the opportunities, and ways to promote the field of human services. I think a lot of us are jealous of STEM and how, that's become the big thing, and they're in schools, and it's that career of the future. But what we would like to also bring to the forefront is the fact that we also are a world that everyone sees is disconnected from each other and society, that loneliness pandemic. And for human services, that's an antidote to a lot of the things that we see. And so we would like the opportunity to bring that to younger people and to put that at the forefront of really rewarding careers that are essential to making Kansas a great place to live and work and to keep our communities and our families together.
Very good. Thank you very much, Rachel. I think we have another question here and third and maybe final from Dr. Clifford.
Thank you for indulging me, Mr. Chairman. For either of you, I wonder if the faith-based organizations have weathered this a little better. I know in Montezuma, Kansas, they take care of their community very well. A lot of us would like to convert to their religion just to be cared for in our old age. So would you comment on faith-based institutions?
Yeah, this is Rachel Monger with Leading Age Kansas. Obviously, faith-based is what we do, and Montezuma is also in our membership, and they are absolutely wonderful and beautiful in every way. Faith-based sometimes fares better. As you pointed out, they have that community that surrounds them. They have an opportunity to do fundraising. You will see actually in my written testimony, one of our members, I believe it's Bethany Village that's in there, who are Lutheran sponsored, they talk about the fact that they have to fundraise to make up the Medicaid difference, and they're able to do that, but it's not sustainable. We have church issues, right, and faith-based issues as well in modern society of trying to keep those going and make sure that they are strong and involved in their communities at all ages and levels.
Very good, Rachel. Other questions? Yes, Representative Gardner.
Thank you, Mr. Chair. And thank you, Rachel and Linda, for these presentations. If we may, could we shift gears here just a little bit, away from the problems of the present and where we are and how we got here? Would you mind just very briefly give us your perspective in the 10 or to 20-year range from now? We know what the demographics are. I'll be 90 by then, and so, I'm looking out for myself here. When you look at that time frame in the 10 to 20-year range from now, and not worried about how to get there, but what would a good system look like, in your opinion, If you could just give me your thoughts on that, not necessarily how do we get there. Thank you.
What an excellent question, and a hopeful one, too. It does allow me to talk about what could be the
Reintroduce
good
yourself just for
things.
the mic.
Sorry, Rachel with Leading Age Kansas. Our national association, Leading Age, does a lot of future thinking and looking at different models, because nonprofits do tend to have a bigger range of what they do. And it is a lot of questions about serving people in that middle class. We've got Medicaid that helps people who spend their assets down. We have rich people who can get whatever they want, right, basically. But the middle class people, how do we serve them? A lot of it is that spectrum. So it's care at home. It's also maybe diverting low-income people away from nursing homes as much as possible by allowing them to live in HUD housing with services brought into them that also is cost-effective. We also would love to see in rural communities be able to have less fractured services as well. We have our critical access hospitals that do a great job, and they have long-term care units, and they have home health. That's quoted in my testimony as well. So being able to sustain that will take a lot of work at the federal level, because it's the federal government that determines a lot of the programs that we use and funds those programs. So our national works with CMS a lot on how do we make this system sustainable, because right now Medicaid is not. So they're looking at a lot of different ways, and I love that Chairwoman Landwehr brought up long-term care insurance and long-term care partnerships. One of the future things that Leading Age talks about a lot is sustainable financing, and we cannot do that without expanding access to long-term care insurance.
Very good. Thank you, Rachel. I think we have then a question again from Representative Dr. Bryce.
Thank you, Mr. Chairman. I have a question for either Linda or Rachel, be fine, especially about long-term care planning and future planning for your industry. We've learned in other committees and in other data that many of the counties in rural Kansas are losing 10% of their population or more per decade. And I'm wondering how much is that playing into the closure of nursing homes if we're losing 10% or more of our population per decade, if that's a factor, or if perhaps the increased age of the general population may be countering that. Oh, thank you.
Thank you. Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living. Excellent question, and I think that is one of the leading issues as far as the challenges in rural and frontier. If we're losing 10% of the county, which 10% is it? Is it the working age? Is it the elder folks that we are losing to death? Is it a combination? I think in many instances, who stays in the county are the elders and the most frail. And the ones who are leaving are the ones that are the mobile workforce that may be going to the city, or they may be going to another state, depending on their circumstances. So who is left is where our crisis lies, because those that are left in the county are finding little or no resources. There's no tax base to have a county-supported nursing facility. Not every faith base can build a home in the community. So you're looking on a private entity that takes Medicaid to staff from where and how, I don't know. A facility that's paying, as Rachel said, 10% less than what it actually costs to take care of the person. So if the average cost of a Medicaid person, if the average pay, is $200 a day, and that's 10% below what it actually costs, how many people can you take care of and sustain that loss? And that's the crux of this position that we're in, because yes, funding's not going to solve everything, but funding's needed to keep the lights on at least. We cannot keep losing money.
Very good. After Candy Bribe, I'll move on to Representative Blex.
Thank you, Mr. Chair. I know it took something. It's kind of a comment, I think, under the able leadership of our Madam Chairwoman. I remember last year that, and COVID kind of brought this crisis, that we had to actually, and I guess it was my fault too, I actually chastised the trade associations for opposing a CNA training of having a requirement of 90 hours when we had to go down to, I don't remember the classification, down to 50 hours. And so we had an association that really wasn't paying attention to what was going on in their world, and I understand patient and employee training, that is important, don't get me wrong, but at the same token, we didn't really bring that about to allow an LPN to be able to train a CNA before legislation took an RN. So I think we've done some things at the state level that is making things easy, but yet we're still dealing with this issue. And I kind of think this partnership has to be that, and I know you guys are struggling and working, but it has to be something that you're on top of too, the associations are on top of, and almost not let it get to this crisis point. Any comment to that, or, I mean,
You don't have to comment, Rachel.
Yeah, you don't have to.
Did you have a question, Representative?
No, it's just a comment.
Okay. Representative Landwehr would like to help us out here.
Well, no, and I mean, that's a really, really tough question, and it's one of the things that a lot of us are working behind the scenes is with our professional organizations to see what they can change. You know, how do we take and get for someone that decided to be out of the workforce and get their CE, can we put them back into the workforce because now they're ready, and have them work on their CEs while they're doing it? So there's a lot of things going on with that. I know the BSRB board is getting ready to bring us a bill that will do some of that. Did it go far enough? I don't think it did, but it's a start, and they listened to us. We're visiting with our universities. How do we get the healthcare industry, and it's not the only one that's having workforce, but it's this here is truly impacting lives every single day. I know of an individual that was being prepped for surgery, was ready for surgery, and then was told the surgery's canceled because the right people weren't on staff. And that's not an isolated story. That's happening all over our country right now. But we're working with our universities. We're trying to figure out can we get enough clinical hours for our staff. Our universities can produce all the students, but if we can't get the clinicals, it doesn't work. And we have to get outside of what we've been doing and change it. For example, a lot of times they want them to get certain training, and the labs and stuff are only available during the first shift. Well, maybe we need to rotate some of those shifts. Maybe we need to go to some simulation, which the simulation today is absolutely incredible that you can do training on in healthcare. Should you only do simulation? Absolutely not. You still have to understand how to work with the patient. So people are working on it. We just don't have the solution yet.
Yes, thank you, Mr. Chairman. And you sort of touched on this earlier, and in the survey, it looks like, and either one of you could answer this probably, but several facilities turn away patients. So just where do those patients go? And then looking into the future, is there any risk that the state of Kansas could just be short beds across the whole state and have to, there's no place to send people at that point? I guess what would be done in that case? And I guess where we are right now, as far as like maybe total state capacity when it comes to number of beds versus number of people out there. Thank you.
Representative Landwehr is going to respond to that. Thank you.
Well, and if either one of them want to do it, I don't think that we have an answer today where it is that we take them and it actually happens. We just had the Masonic home shut down in Wichita, and people were scrambling to try and find beds. So it's not just a frontier and a rural area issue that we deal with. So it's at crisis. It's a crisis in our clinics. It's crises in our hospitals, but it's been a big deal in the nursing homes because these are a lot of, not mobile individuals that are in our nursing homes. And as you heard Linda say earlier, no one wants to go to a nursing home. So I don't know if that helps answer your question, but we don't have the answers yet. And we know, but it's happening where there aren't beds. And so family members are having to step up and try to figure out how they can take care of their loved ones.
Well, I'm going to,
Just a minute.
yes,
The
ma'am.
only reason that I'm interjecting in this here is because I'm not always going to put, make Linda and Rachel get, put on the spot with it when, if they want to, they can answer. But I don't think that you have an answer. Am I correct? We're concerned and we're worried and we're looking. Is that?
Thank you, Representative Bergman, and thank you, Representative Landwehr. I'm going to respond to that myself briefly and go on mic and say that these people stay in the hospital, and it log jams the system, and then you don't have beds for that patient getting out of surgery because that bed is still occupied by a person that should be in a long-term care facility, in a nursing home, or wherever. So it's created just an ongoing ripple effect that is just getting worse and worse, and it's becoming big waves of healthcare inequity, and it's not good. But I do have some comments, and I have a couple of questions, and I think you may want to jump up on some of these. On the point of overregulation, as a healthcare provider watching it for over 40 years and having been a nursing home director for 35 of those 40 years, I'm really troubled about, and I wish they were here, some of the regulation people. Is there anything that we can do from the state standpoint about overregulation? I think that the long-term care facilities are the most overregulated entity in healthcare delivery in our state. I really do. Is there anything we can do about overregulation from a state standpoint? I know much of it's federal driven, but do you have any input or ideas on that? Do either one of you want to jump up and handle that?
Thank you, Mr. Chair. Linda Mowbray, Kansas Healthcare Association. Overregulation is a burden. Regulations are necessary. We're talking about frail individuals that are needing care. So oversight is necessary. But there are a couple things that I would ask you to consider. One is joint accreditation, quality-based programs, such as the Baldridge, where you're looking at systems where the entire team is working together to make quality improvement a reality. American Healthcare Association works on a Baldridge-based program that does what many, many companies have done. You have to look at yourself first. You have to be able to recognize your weaknesses at first and then build upon that. So that's one idea. The other, the joint accreditation, that's having an outside entity that's not the stick, that's not the regulator, come in and help quality improvement, help quality systems. Right now, the Joint Commission is active, and they are available to work with our nursing facilities. It's quite costly. I'll be just real upfront with it. But they do help systems. The third thing that I would propose is surveyors with KDADs that come into our buildings. They are following federal regulations as well as state regulations. But they are people. And people have opinions. And people have biases. And so to say it's an impartial system, that's not realistic. We're people. We're going to have our opinion. So let's look at that resource coming in and use part of that time to teach and train and mentor. Now, I realize the state is short on surveyors too, because they use primarily RNs, and they can't pay what the going rate is right now, so there are shortages. But instead of continuing to just, you did this wrong, you did this wrong, you did this wrong, teach me how to do it right. Mentor me, counsel me, help me.
So when it comes to accreditation entities, is that something that an organization or even the government could provide as a means to correct some of these deficiencies before they become JTAGs, which is, the haunted JTAGs that we deal with. And for those of you that don't know, you don't want a JTAG, in a nursing home. I mean, that's bad. So, and I've dealt with that as a director before. So my comment to you is if there was some way to provide that oversight without it being such a financial burden, that would be helpful through policy or through whatever. I mean, that's one solution that you would say might work. Is that true?
Yes, sir. I would say that that is a solution that would not only take the financial burden off, it would provide the outside resources to help mentor and counsel and teach and educate, but it also could be a relief for the state survey agency as well. Because for those who have reached a certain level of accreditation, maybe they don't get surveyed as often, or maybe their survey is more of a desk review, that the accountability goes to the accrediting organization instead of the state having to find and recruit and train and pay those surveyors. So I think it's a good opportunity for solution.
So that's an opportunity we can talk afterwards. And then number two, looking at some of the issues raised about wage scale and gosh, pandemic wage scale is like a rocket going up in the sky right now. Plus, you had the disincentives that Representative Blex spoke about, and you've got a perfect situation for relying on staffing agencies way, way too much. So that leads me back to the rates, which you spoke about, and I am happy and proud to say that, our session last year did see fit to finally fully fund rates for the first time in a long time. But I need I need reality. Where do those, someone needs to tell me as a committee member, and these committee members need to hear this, where do rates need to be? I mean, how much do they need to go up this year? I mean, it's not all about money, but at the end of the day, when I know how we're relying on these entities, these hired gun agencies, it's ridiculous how much it impacts our overhead. So what do we need to do on rates this year? I mean, can someone I'm a pretty simple person, so can you share that with us, please?
The rates, if you will, are based on very complicated formulas that will make everybody's eyes glaze over. But suffice it to say, it is cost-based accounting on audits. It's 3 years of cost reports. So every year, the facility, and right now they're working their tails off getting their cost report for this last year put in. And they are showing what they actually spent on food and wages and real estate property taxes and all of the different business operating expenses. Okay? Part of what the state reimbursement does is looks at the mean. So all these cost reports from all 296 buildings come in, and we look at the mean cost. So for healthcare costs, think of it this way. The closer you are to the person and what you're doing for the person, the higher the reimbursement is. Okay? So if healthcare is paid at 130% of the mean, the property taxes and the administrative and the back office are paid at a 25% less than that because it's that much further away from the person. So the money that you put in that helps the person, you get reimbursed a little better on. But there are caps, and Representative Landwehr can clearly speak to those caps and the budget neutralities and the issues that we have with increasing the amount of funding over and over and over again. You're capped out. And every year, there's about 150 buildings that reach their caps in one or more areas. So they are spending more money than what they're able to get back. Now, I know that's a really, really complicated, long way around the barn to say they may spend $100 and be eligible to get 90 of it back, and then based on survey and performance and other things, they may only get $85 back instead of that 100. And in the meantime, the inflation goes up. You're getting paid on what you already spent, if that makes sense. The last 3 years of what you already spent, and you're not getting all of it back. That's where the funding issue is a problem. Later on this year, we will have a proposal that looks at helping out those buildings that do more Medicaid, that if the percentage of their census is Medicaid, we are going to introduce a funding mechanism that will hopefully help bolster that. Because as a state, those are our people, and we said we'd take care of them. So let's take care of them.
That proposal will be then for the 24 session?
Hopefully yet for this session.
This session, okay.
To go into effect hopefully in fiscal year '24.
Okay, I have one more burning issue I want to bring up with you, Linda, and you can address this, and thank you very much.
Sure.
As a provider of health care, and I've got some friends up here that are also providers, and they deal with this also. We all deal with liability issues. And I know from the legislation and how it unfolded during the pandemic, I really felt that we almost singled out the nursing home industry and said, no, you don't need those. You don't need that help. You don't need that protection, even though you're taking care of the most vulnerable, the sickest, the folks that are at the end of life with COVID or certainly prone to get COVID. And yet, we're not going to afford you any liability protections. And I'm not giving a political speech. I'm just observing that was the situation. I'm not going to say Democrat, Republican. I'm just saying that's how it went down. Now, going forward, are there some policy opportunities to permanently codify some liability protections for your industry that we have not enjoined?
I believe that in order to level the playing field, if you will, with liability insurance, we have to acknowledge what the Healthcare Stabilization Fund is about and who those members are. We are part of that class of healthcare providers, and we have to be treated as such. How we codify that, sir, I don't have the answer, but I just believe that, if you are in this class of providers, then treat us fairly, because you're right, we were singled out.
I just want to be sure the committee understands that. We had legislation that was bodacious to protect providers and others in healthcare, mid-levels, so forth, but the nursing home industry was not afforded that protection. And there was a lot to that at the time in the 21, or in the 22 session. So anyway. It is nearing the end. Is there any other last gas questions? Yes, Representative Barth.
Thank you, Madam Chair, and appreciate the information as well. And I don't know if this, did I say it wrong?
That's okay. I told him I had a sex change. It's fine.
You're the chair today, Mr. Chair. I don't know if this is a question for them or not, but it has more to do with, is there anything that we're doing to help these aging folks in home that are to be able to help the families take them in because of the lack of beds so that they don't end up in a county type of situation that you described? Can you address that a little bit with the group here, please?
Thank you very much. And I'm going to defer to Representative Landwehr, who has probably a wealth of knowledge on that subject.
No, these ladies out here have the wealth. I just have touches of it. Well, a person could be with a family member and get HCBS services in the home. A lot of family members don't want to take care of the elderly, and maybe they can't take care of the elderly. Maybe they've got two working families. So it's the HCBS waivers, which is where we keep most of our elderly in their home.
And we have provided better funding for that here recently, but we can still do better, so. Any other questions? I guess without any other questions, we will then stand adjourned, and our next meeting will be next Monday at 1:30. Very good. We will stand adjourned.